for a period of time, pain became a really big deal in which healthcare professionals, it seems like that was one of the questions they asked everybody every time. How is your pain? And the experience of responding to pain kind of blossomed. What was that all about?
Well, there was a concerted effort to include pain as the fifth vital sign, and that, I don't have the exact year on it, but it was in the late 1990s, I believe, when pain was added as a formal vital sign, which meant that it was asked about at every patient visit, regardless if you came in for something that was clearly a pain-related complaint, or if you came in for, you know, I don't know what, a cold. So it became a real focus everywhere, and in part, that was an effort to treat pain better, but also it may have been somewhat influenced by the opioid industry's bringing more attention to pain and encouraging more treatment of pain.
Interesting. Let's come back to that here in a bit, because opioids are a big concern across the country, both in terms of both extremes, an overuse of opioids, and then for people who have chronic pain, the response to what's the perceived overuse of not being able to have access to that, which maybe we can talk about what are the options. But in terms of brain injury, are there typical pain, what would I say, outcomes or experiences from, say, traumatic brain injury?
Well, so the estimates are that, you know, somewhere between, it varies pretty widely at what you look at, but the estimates are that somewhere between 20% and 70% of individuals with traumatic brain injuries will have some sort of chronic pain as a consequence of their injury. And the most common of all of them would certainly be headache. Headache is very, very common, but then other types of pain that are also very common are just musculoskeletal pain, neck pain, shoulder pain, back pain. Those are very common, but you know, all types of pain are possible, and generally probably amplified in the context of brain injury.
And understood. The difference between the immediate pain, let's just talk traumatic brain injury for a second. In traumatic brain injury, people who might have a car crash, for example, would likely have, in addition to if they had a brain injury, other bruising or injuries, tissue injuries, hopefully not too severe, but pain would be an understandable outcome. Is there a difference between the pain that resolves relatively quickly in days or perhaps weeks and pain that doesn't? What is the nature of chronic pain, and how does that change how the body works, or how do people experience chronic pain differently than more short-term pain?
Sure. Well, let's talk first just about chronic or acute versus chronic pain in general, and then we can talk specifically about some of the particular challenges that would be present in brain injury. So acute pain is just as it sounds, acute, right? It's in response to an injury, a surgery, a car crash, something like that. And it really is just about the danger response to actual or perceived tissue damage. And that usually resolves when the tissues are done healing. So acute pain is, we generally think of it in, you know, sort of that less than 3-week kind of range. And that's very adaptive. We want to have acute pain. People who don't respond with pain, you know, have shorter lives and you know, and less healthy lives. So chronic pain is generally pain that's lasted for greater than 3 months, or for pain that's lasted beyond the time when normal tissue healing has occurred. And chronic pain really represents a chemical and even a microanatomical change in the central nervous system, and in a way that's kind of self-perpetuating. So you can think of it as a bit of a faulty or an oversensitive alarm system. So we just back to the sort of general how pain works, right? The body sends messages, which are just chemical and electrical signals from the body, and it's just messages. The messages themselves are not pain. The messages come, they go to the spinal cord, they go up the brain, where the brain and the frontal lobes and the executive centers, memory centers of the brain make a decision about, is this dangerous or not, and am I going to respond or not? In the case of chronic pain, the messaging, the executive centers in the brain and the messaging center in the central nervous system has become oversensitive. And it is sending pain signals even in the absence of any of the chemical and electrical signals coming from the body saying that there's danger. So it's really a biochemical and, as I said, microanatomical change in the central nervous system. And you get to a point where normal, previously safe activities are now perceived as dangerous and therefore stimulate a pain response from the brain. And so it's also a psychological experience because it triggers two really common models of coping, either sort of this endurance model of coping, so where people kind of just grin and bear it and put on a happy face and sort of have a tendency to overdo and overexert, and they minimize pain, they try to distract from pain. And what that really puts people at risk for is just disrupted healing. You know, they're in the process of healing, but they're pushing through and they're not listening to their bodies, they're doing more. And you get disrupted healing, which only serves to sort of reinforce more pain signaling. And another model of coping is a sort of a disability cycle model. So you have pain, and we become, and along with pain, all the things that come along with pain, you know, loss of identity, loss of ability to function in ways that you would have normally. There can be a fear of re-injury, which can lead to a fear of movement, which can lead to less movement, which leads to stiffness and dysfunction in sort of our large body muscles and our body chemistry, which leads to more, you know, physical and mental isolation, which reinforces back to more pain. So that's, you know, that is also involved in the chronic pain cycle. Is this? So it all is sort of this this sort of pathological positive feedback loop that can get going in chronic pain. And in particular, in folks with brain injuries, both in the acute phase of brain injury and all of those secondary pieces of brain injury, right? So we have the acute injury where there's tissue damage, and then we have those secondary chemical processes that occur for months afterwards, right? Where there's increased inflammation in the brain and in the central nervous system. There's decreased ability to utilize energy. There's impaired, cognitive function. And so dealing with pain in a brain that already is sort of metabolically and chemically challenged, and when you think about the brain as being the most metabolically needy organ in our body, right? It's this tiny organ about the size of my fist together, and it uses 20% of our body energy. And every minute, a liter of blood is pumped into the brain. So it's incredibly demanding. And you injure it, and you increase the demands, and then all of that chemical setup really predisposes to some of the similar chemical things that can go wrong associated with a transition from acute pain to chronic pain. That's why it's so much more prevalent.
Thank you. So what I hear you saying is that there are at least two models. One is, if I can paraphrase, a more of a stoic model, perhaps the Norwegian bachelor farmer, where you just kind of grit your teeth and move through it, not letting yourself perhaps have enough time that you might need to heal. But then on the other side of that is kind of pain, wanting to avoid the pain and therefore limiting physical activity. For example, if I'm just going to bring one up, if walking brings on pain, then, you know, avoiding walking because you're scared to feel the pain because the pain signal means danger. How does a person find the sweet spot? And it's different for every person, but who can help somebody, or what is the if you will, a common guideline for somebody who might be concerned that they're moving from acute to chronic pain, to know that they're doing enough, but not too much.
Mm-hmm. Yeah, it's a fine needle to thread sometimes.
Right.
So pacing, I mean, pacing is probably one of the very most important things that we need to do, and it's difficult. So doing little bits of activity, taking a step back, reassessing, and really developing, maybe for the first time ever for some folks, a real sensitivity to how their body is responding to what they're doing, right? So doing a bit of something, taking a step back, assessing how you're feeling, what's the status of your emotions, what's the level of pain, and then reassessing. Maybe next time you need to do less, maybe next time you can do more. So that's really, so reapproaching, pacing, sometimes obviously working with a professional like a physical therapist, for example, who can help individuals develop programs that are, appropriate for them. I mean, one unfortunate consequence of dealing with chronic pain is that the brain there's the risk that the brain can start to become a little less self-aware, where we become less aware of our bodies and how we're moving or how we're holding our bodies, or and that actually our brain maps of our bodies become a little foggy. They become less distinct. And so people's actual intuitive awareness of sort of, how they're holding their body in space, and maybe they need to change that position, can become challenged in chronic pain. So that working with a professional like a physical therapist can be really helpful. Also experimenting with other kinds of movement modalities that are really have been shown to help us develop that body awareness again. So for example, Tai Chi, it has a lot of evidence as being helpful in many pain conditions. And it is, very slow, it's a martial art. It's a very slow, gradual, precise way of moving the body, and is appropriate for people in wheelchairs and people who with mobility issues and balance issues and, cardiac issues. It's appropriate for everybody, and it can be adapted. And so things like that. So finding new ways to move that are safe and sometimes requires somebody else helping you with it.
So Tai Chi, which it's available perhaps in many places in the country, there are certainly parts of rural America that I don't know have access to that. However, it seems to me from when I travel, you can't swing a cat without finding a yoga studio. Is yoga also something that people could engage in?
Yep. So there's definitely evidence that yoga is helpful in the context of pain, and yoga likewise can be adapted to chair yoga, wheelchair yoga, yoga that's, I think many of us have like an automatic thought about what yoga looks like, and it can look like a lot of things. So there is definitely evidence that yoga is effective for pain as well. And I will say from my time at the VA, yoga and Tai Chi are both modalities that achieved a high enough level of evidence of effectiveness that they are paid for and incorporated regularly into the VA model of pain care. Likewise, modalities like chiropractic care and acupuncture are also validated and have been included in the VA interdisciplinary model of pain care, which I think as a model of pain care has been kind of at the forefront of the next generation of pain care approaches. So those would also be options for professional sort of hands-on help. Massage as well can help folks become better in touch with what's going on with their body, just with even, many people who experience a chronic pain condition will become afraid of sensing anything in their bodies, and become progressively sort of cut off from anything pleasurable, not pleasurable, because it all starts to feel overwhelming and unsafe. So even something like gentle touch and massage can be helpful as well.
Helpful. What other things that did you see or have you seen? You talked about movement activities, Tai Chi, chiropractic, acupuncture. How about things such as diet? Does diet have any interaction with people's experience of pain, or can people choose what they eat and or drink to either try to decrease pain or try to watch for patterns of things that trigger pain?
Oh, yes, definitely. It's probably one of the most powerful things that we can do to impact our health, no matter what our health condition is, positively. So there's, as it feels like we're transitioning into just what we can do about pain, and treating pain. I just want to preface. I want to frame all of that with, I think, going into any treatment option, approaching what to do about pain should always be framed with our expectations about what's, expectations, period. So many people, when they would come in, their request to their healthcare provider is just make the pain go away. I don't want any more pain. It needs to go away. And as reasonable as that expectation, as far as I can, it's understandable to want that, but it is not a good goal to have, because it's very unlikely that, particularly in a chronic pain condition that's been around for many years or decades, that we can make the pain go all away. And so a much more helpful and successful goal of treatment is to improve function. And so if we think about, if we focus on improving function, that's something that's accessible to everybody, no matter how long they've been living with pain. So that's important. But in terms of things that you can do, so diet is what you asked about. And certainly there's a lot of evidence that in following a more anti-inflammatory diet, or maybe more of even a Mediterranean type of diet, is associated with lower rates of, lower reports of pain intensity and overall improved function. And
so those are two phrases you just used, the anti-inflammatory. I know a little bit about that. A Mediterranean diet, it's quite common, but give us some examples of both of those before we get too far off.
Sure.
If I'm ready to go have lunch now, and I'm sitting in rural Montana trying to think about what's in the fridge, what would be some good choices, so to speak, that would guide me? Just basic things that I might look towards and perhaps think about decreasing.
Yeah, great question. Well, one general rule of thumb about eating for health, I borrow from Michael Pollan, who's an author who's written a number of food-related books, and this just reduces it to a sentence, eat food, mostly plants, not too much. And I think that's very just basic. Now, determining what's food and what isn't food is sometimes difficult. So I think so food in general is not processed. So if it comes from a package, a box, something that didn't need to be refrigerated and sat on the shelf of the grocery store for weeks and months, the likelihood of that being food is much lower. So not processed food as much as possible, as many plants as possible, and as many kinds of plants and as many colors of plants as possible is another good rule of thumb. And not too much in general is also a good rule of thumb. So specifically, an anti-inflammatory diet generally encompasses lots of plants, healthy fats like olive oil and avocado oil and coconut oils, healthy proteins like fish and beans and chicken, lean meats, and then a real minimization or even exclusion of things like dairy and gluten and processed sugar, added sugar. And that's the basic framework of most anti-inflammatory diets. A Mediterranean diet is very similar to that. The thing that's special about a Mediterranean diet is it just includes really a lot of fish and a lot of olive oil. And so very heavy in specific kinds of fats that we know are very helpful to the brain, but also in reducing inflammation in the body.
Thank you. One of the things you mentioned that I want to come back to is plants, and you said lots of colors. And I'm guessing that that's not, actually I know, but why the colors? I mean, why are colorful vegetables more important or more helpful than just green vegetables or, what would I say, radishes, white radishes?
Well, so green vegetables, green is a very bright, vibrant color, so those are good.
Okay.
But in general, in the plant world, the more colors that are in, the more brightly colored all the way through the vegetable. So for example, your example of a radish, which is red on the outside but white on the inside, is not the same as, say, a raspberry, which is deeply colored all the way through, or a beet, for example.
Okay.
So in the plant world in general, those colors are bioflavonoids. They're plant chemicals which have a lot of, in human beings when we consume them, anti-inflammatory and effects, and many micronutrients that are helpful for people. And our brain runs on those things. In addition to just energy, our brain needs lots and lots of micronutrients to do the work of being a brain, of thinking and feeling and processing and all of that. So, yeah.
Helpful. So you brought up another, I'm sorry, getting a little echo here. You brought up a really interesting sidebar, and I tend to go down rabbit holes, but food choices and foods, as you well know with your husband, me, are really resistant to change. We like what we've grown up eating. The flavors of our childhoods inform a huge range of our experience with comfort, with safety, with familiarity. So for folks that might be trying to move towards some of the concepts you talked about, eat food, eat mostly plants and not too much, but what about adding supplements? So trying to get micronutrients and or nutrients and or anti-inflammatory components by taking supplements. We have on our counter a whole range of supplements that you brought in to experiment with us on. And what have you found with your practice that seem to give folks the best results?
Well, that's a big question. It could be really broad, but I'll narrow it to just the context of chronic pain, or pain in general, and maybe brain resilience. So a few nutrients that have been shown to be helpful in the context of chronic pain. There are three basic ones that I think are accessible to most people. So fish oil, or omega-3 fatty acids. So fish oil or omega-3 fatty acids are essential fatty acids. That means that they are essential for our optimal and normal body function, and we also can't produce them ourselves. So we have to take them in our diet. And the most concentrated source of omega-3 fatty acids is in fish. You can get it in other sources too, but in much, much smaller amounts. So if you're dealing with something like a brain injury or chronic pain or both, there is significant evidence that fish oil can help optimize your brain's ability to be resilient, repair itself, and you can help to tip the balance, your inflammation balance in your body more in the anti-inflammatory as opposed to pro-inflammatory, or making more inflammation. So fish oil is a wise and safe supplement that has benefit in nearly all pain conditions and in brain injury. Magnesium is another supplement that has been shown to be helpful. So magnesium is a mineral which is really important for, it needs to be around in the brain so that it can produce all of the chemicals that it uses to do its work. And it's also very important as a, it has some relaxant properties on muscles. So a lot of people with chronic pain have tight, stiff muscles, and they have trouble relaxing those, and magnesium can be helpful with that too, even some with spasticity. And then vitamin D is another one. So vitamin D has been, having inadequate vitamin D levels has been shown to increase pain experiences. Vitamin D in the brain is a neurohormone which influences our brain's ability to make, again, its neurochemicals that it does its work with. So not being vitamin D deficient is also important. So we can take a supplement of vitamin D, but we can also get outside in the sun and make vitamin D through our skin, and that usually actually works better. So those are 3 supplements that have evidence of being helpful in pain in particular, and that are sort of widely accessible and at least in the case of vitamin D and magnesium, are very affordable. Fish oil can be a little bit less affordable, but it's still really, really useful supplement to consider making a priority, or eating plenty of cold water fish, fatty fish like sardines and herring and salmon and mackerel, things like that.
Okay. So if you were, if somebody, again, I know this is, you can't give medical advice, or you said there's no substitute here, but is it possible for you to give a general dose that would be safe and a place that somebody might start if they were going to go to a drugstore and look at, I think you said fish oil, magnesium, and vitamin D? What kind of dosages would somebody be looking for in the, what numbers or units would be people look for?
So generally fish oil is between about 2 grams and 4 grams a day. There are many studies, particularly in brain injury recovery, that use much higher doses of fish oil than that, like 16 grams a day in acute recovery from brain injury. But I would say that generally the consensus is that somewhere between 2 grams, so 2,000 milligrams, and 4,000 milligrams a day is safe and can be helpful with fish oil. And it's really best to take that with food, particularly food that has a little bit of fat in it. We absorb it better that way. And I would split that up. I wouldn't take 4,000 milligrams all at one time. I would split it up and take it in the morning and in the evening kind of thing. Magnesium is generally about 400 to 600 milligrams a day. I generally recommend that people take that at bedtime because of the muscle relaxant qualities that can help with sleep. And vitamin D really depends on what your vitamin D level is. And so I advise that people do get their vitamin D level checked. And vitamin D levels are normal. Vitamin D levels range a tremendous amount, somewhere between about 20 and 80. And I tell people that, at least when I'm working with individuals, I would like to have their blood level somewhere around 50. And so I will supplement to get to around 50, recheck and adjust the dose as indicated.
Helpful. Thank you. What about brain injury, pain, and sleep? Sleep is a challenge for many people in the population in general, but it's got a particular, it's a particular risk factor after brain injury. Is struggling with sleep related to experiencing more or less pain?
Absolutely. So sleep, good sleep is good pain medicine. And poor sleep in anybody, brain injured or not, is going to reduce our brain resilience and our stress resilience. And most of us, when we are poorly slept, and more stressed. We make poorer choices with regard to what we do during our day. We're less likely to exercise. We grab the convenience food that sounds good. And so sleep is fundamental to good brain health and good mental health and good chronic pain management. So and I know you just recently had a webinar on sleep and brain injury, and so I'm sure there's a lot of good information in that one. Routine is extraordinarily important. Having a regular sleep time, a regular wake time, going to bed when you're sleepy, not before, getting out of bed if you're not sleeping, and doing something else calm and relaxing, generally not on a screen, getting physical activity during the day, getting out into the bright light, in particular in the mornings, has been shown to help with sleep at night. Avoiding caffeine and alcohol, particularly in the evening hours, but perhaps entirely. Those are all things that people can do to help improve their sleep.
So it gets complicated when people have pain that's interfering with sleep. And I've worked with many people who feel like if they don't take pain medication to be able to sleep, they can't sleep, their pain gets worse, they need more pain medication, but then they're taking pain medication to kind of prevent, which actually ties in with something that I wanted to ask you, so I want to hold that thought for a second too, that it used to be that physicians, I know I was told many times, to stay ahead of your pain, to take pain medication preventatively, because if you can stay ahead of your pain, it won't become as severe. Is that still what common thought or common practice, or is that shifted in line with being more functional versus more pain averse?
Yeah, that is kind of shifting sand right now. This idea of regularly taking medicine, but particularly some medications are more problematic than others. So I think that for somebody who has chronic pain, there is a very high likelihood that they're going to regularly be taking a medication to help with that pain. And that can be fine depending on the medication. I would say so having a flare of pain and having pain flares while you have chronic pain and then is a normal thing. Everybody who has chronic pain will also have flares of acute pain. And that's when they're much more likely to want to use more pain medication, and that makes sense. But anticipating flares in pain and planning for them with sort of developing a plan that includes tools other than medications, other self-management tools is really, really important. But there used to be, back when I was doing my medical training, there was the thought that if you just used a lot of opioids right off the bat when someone had an acute injury, that you would prevent the chemical cascade of progressing into chronic pain. And now we know that that's really not the case. So we know that for opioids, for example, or the medicine or the sort of elephant in the room, the thing that everybody talks about. So opioids in a chronic or in an acute injury, if I have a motor vehicle accident or I've broken my arm or I have a massive injury, I want to have opioids. That is appropriate use of opioids. We know, however, that if we extend use of opioids beyond about 5 days, that the risk of developing dependence, physical dependence, and psychological dependence, and then addiction perhaps go up significantly with every day that we continue to use that medicine. But we also know that people who are treated with opioid medicines for longer than 5 days post-operatively or post-injury will also are more likely to go on to experience chronic pain. Because of the way that opioids chemically shift what's called the microglia. So these kind of other cells in the brain that aren't neurons. They're not the thinking cells, but they are the support and kind of immune system cells of the brain. That those specific cells, which outnumber our other cells 100 to 1, are become activated and enter an inflammatory cycle in response to chronic opioid use. And that those microglia are what sets up the chronic pain cycle in the brain and perpetuate it. So we know now that using opioid medication long-term or regularly really contributes to overall worse pain outcomes and overall worse functional outcomes in people with brain injuries, but also individuals without brain injuries. But I would say that the risk is even higher in people with brain injuries because, again, their brain chemistry is just changed and is more susceptible.
Thank you. Wow, it kind of is. I remember when I had a back injury and I was prescribed some opioids to manage my pain for a couple of weeks afterwards. Just after 2 weeks, it felt like if I didn't have that medication, I was going to be incapacitated. And, you know, knowing that this week there was a $25 billion settlement by Purdue. Anyway, we can go down that rabbit hole about the politics of opioids, but that's a big deal. And so for people who might be in that position around the country where they've been on opioids for more than 5 days, and they're listening to us on the webinar today, and they're a little anxious about, holy cow, I mean, I've been told I'm going to have to come off of these. How do I do that? I mean, is there hope not to just feel like you're having the rug pulled out from under you?
Yeah, and I think that, you know, physicians and healthcare providers can get really freaked out and scared about this. And I would say that most people are not comfortable treating pain. Most people are not comfortable talking about pain. None of us wants to have pain. And physicians in general don't have really great training about how to manage pain. And so with all of the emerging evidence about the risks of using opioids, I think that there is a real hazard that, and I've seen people running into this where their physicians just say, I'm not doing it anymore, and they just take them all away. And that, of course, is very scary for the individual, for the patient, and also potentially dangerous for them because of withdrawal, and it's just unnecessary to do it that way. So I'd say for folks who are struggling with opioids and would like to get off of them, that you find a provider, if you have access to it, you know, a range of providers, maybe work with a few of them and decide, choose one who will take a paced approach, a gradual approach to medication reduction, and at the same time help you get into other supportive modalities of treatment, good physical therapy, maybe Tai Chi, yoga, really utilizing those self-management techniques, focus on diet, and maybe the utilization of other types of pain medications, which are at this point anyway, shown to be safer options. You know, with medications, there is no free ride. There is always a price to pay for taking a medication that's beyond the financial costs of the medication. And so, you know, in the pain, kind of conventional approach to pain, medications that typically get used fall into about 3 or 4 different classes, but we have our regular analgesics like Tylenol and ibuprofen, and those actually in many studies have been shown to be as effective as opioids for both acute and chronic pain. They both have their limits of safety, and some people are not appropriate for one or the other, given if you have liver disease, for example, Tylenol is not a good option. If you've got kidney disease, you know, ibuprofen is not a good option. But so we have analgesics, we have topical medicines, like lidocaine and capsaicin and something called Voltaren or diclofenac, which is like ibuprofen that you rub on your skin. We have muscle relaxants.
Are those all, by the way, are all those prescription or are they over the counter?
So capsaicin can be found over the counter in a low concentration, lidocaine as well in a low concentration, but higher, more effective concentrations are prescriptions.
Okay.
There are muscle relaxants, which can be useful, but at the same time also have some sedating qualities and some addictive qualities, and so need to be used with some degree of caution, but are certainly safer, we think, than opioids. So things like baclofen or Flexeril, cyclobenzaprine. Then we have the antidepressants that are analgesic, like Effexor, venlafaxine, or Cymbalta, also known as duloxetine, and some of our older medicines like nortriptyline and amitriptyline. And those can be used and can be very helpful, particularly if people are struggling with mood issues in addition to pain. And many, many people who have chronic pain also have chronic problems with depression or anxiety, and we know that improving someone's depression or improving someone's anxiety improves their pain as well. So, and then finally we have medicines that are known as membrane stabilizing agents, things like gabapentin and pregabalin, and those are helpful more for nerve-based pain, neuropathic pain. They get used a lot. They're also not entirely safe and have sedation as a side effect and some cognitive clouding as a side effect. And then finally the opioids. So if you're trying to transition off of opioids, smart utilization of some of these other options, these other agents, but also taking a interdisciplinary approach, so involving a physical therapist, involving a psychologist if you have access to one, or even a pain psychologist if you have access to one of those, involving a nutritionist or dietitian. Those are all pieces of an interdisciplinary team that can be really helpful for making changes in your pain medication. My experience is that people feel better as they come off of their opioids. Well, not as, they actually, they have a hard time as they're coming off of their opioids, but people in general feel better once they're off their opioids. And their pain level actually doesn't change all that much, and that's the fear that people have, is that their pain is going to become unmanageable, and then that leads to catastrophic escapist thinking, which increases the pain. And what we find is actually that the pain level stays about the same, but their functional level improves significantly.
Helpful. So it's just a 10 minutes before the hour, and this is usually when we pause and take a look at trying to grab a couple of questions. Are you okay with that?
Sure.
Okay. There are three that have come up on my screen so far. One is around fish oil, that you mentioned that fish oil had a potential impact with anti-inflammatory and also pain management potential, but then you also mentioned that it may be a supplement that can be used during an acute phase of brain injury. Is that, there's evidence for that?
Mm-hmm. Yeah, there's actually pretty robust evidence for the use of relatively high dose fish oil in the context of an acute brain injury. There's also evidence that taking fish oil before a brain injury, now nobody anticipates when you're going to have a brain injury, but studies have been done in rodents, for example, where you feed them fish oils before you give them a brain injury and then compare how well they recovered and how much damage was done. And so there's evidence that consuming fish oil before a brain injury is also protective. And then just in the healing process of brain injury, fish oil is helpful, because if you think about it, again, the brain is made of fat, and it's made about 25% of the fat in the brain is fish oil type of fat, this omega-3 fatty acid. And so when the brain is rebuilding itself, reconstructing the damage that was done, giving it the building blocks to do that, especially this really essential particular type, is helpful. And then furthermore, we know that individuals who have brain injuries have a higher likelihood of developing neurodegenerative conditions like Alzheimer's and other dementias. And we know that fish oil is protective in terms of moving towards dementia, that it prevents that. It can help to slow that progression or to help to prevent that progression. So it's helpful on so many levels that it's one of the few things that I encourage regularly.
So, would that also be applicable for acquired brain injury in addition to traumatic? Would there be any issue? Well, I guess I'm just thinking if a friend or a relative had a stroke, as they recover, would suggesting that they are bringing them fish oil be dangerous in any way that you know of?
Well, if someone has had a hemorrhagic stroke or they are taking blood thinning medication after a stroke, that is something to be mindful of, because fish oils do have an anticoagulant effect, so they thin the blood.
Okay.
And so that is something that you would want to discuss with your provider and be sure that generally people who are taking anticoagulants or blood thinners are able also to take fish oil, but there needs to be some adjustment of the blood thinner potentially. So
got it. So talk to your doc.
Yep.
Got it. So there's another question that came in about the utilization or the utility or helpfulness of meditation and or relaxation. One of our listeners said that was very helpful for them after an accident in which they had a brain injury plus chronic pain. What's your experience with that?
Absolutely. We could have a whole hour just to talk about that. I can't recommend it enough. So pain always has an emotional component to it, and particularly severe pain, people can become very panicked and think catastrophic thoughts like, I can't go on with this, and this is the worst thing ever, and there's no way I can do this. And so those kinds of thoughts increase the pain, and working with meditation and working with the ability to trigger what's called your own relaxation response is very, very important. And also with coping with the ways that chronic pain and a brain injury change a person's life. They change your identity. They change what you're able to do. And learning how to meditate, we know, is positive in depression, it's positive in anxiety, it's positive in pain. And so working with somebody, if you have that option, to learn how to meditate or do guided imagery or progressive muscle relaxation or diaphragmatic breathing, or there are lots of different ways to get there, but basically learning what works for you to trigger your relaxation response. And that can be very helpful in helping people get through those waves sometime of pain that are real intense, and they start to kind of panic, to calm down, to distract. So there are a couple of good apps that are free, so that I direct people to all the time. There's an app called Calm, the Calm app. And that can be helpful. It has a lot of free meditations, guided and otherwise. And then Insight Timer. Insight Timer is another free one. But there are also a number of resources available via YouTube, for example, with guided meditations, relaxations, guided imagery, things like that. To also Tai Chi routines. Even simple yoga routines. So there's so much available on YouTube. So that's also a resource for people who might not have access to some of these other in-person things.
Would you be willing to maybe offer us a one-page resource list? I know earlier you talked about some books that had the diet options Eat Food, Eat Plants, Eat Not Too Much, Michael Pollan, as well as some of these apps, and perhaps there may be some other websites or places that people can go to get a bit more information to either take to their healthcare provider if they're not aware of this, or to try to find a way to integrate that into their team. There's one, I guess I should ask you, is that something people could look for from you?
Yes, absolutely. I would be happy to compile a list, and then maybe you could post it.
We can post it on the website, and we can push it out to the people who've signed up for this webinar. So that would be helpful. There's a question about that. And then lastly, there was a question from somebody who indicates that you talked earlier about packaged foods, if it's in a package, and they have a local grocery store that everything's in a package there. Everything's, got shrink wrap on it. And specifically, do you refer to things like packaged beans, bags of beans or rice, or?
No.
Okay.
So
good.
Pre-made processed food that's, again, a good rule of thumb, if you look at the ingredient list and it has more than 10 ingredients, and ingredients that you really don't know how to pronounce, you don't recognize as things like potatoes or carrots or, that kind of thing, that's a food to be suspicious of, that is maybe not a real food. It's more of a processed food. Another rule of thumb I think that Michael Pollan uses is that if your great-great-grandmother wouldn't have recognized it as food, then it's probably not food.
Aha, there you go. If your great-great-grandmother didn't recognize it as food, it's probably not food, which is why we all want to eat what our great-great...
And she'd say, "What is this?" Then that's probably not food.
Well, thank you. It's the top of the hour, and although we could probably talk for quite a long time more, very much appreciate you taking time to talk with us. For those of you on the line, we'll be sending you, pushing out to you both a survey for you to give us some feedback about our webinars, as well as a one-pager that Dr. Lauer, Erika, will give us here in the next week or so. So on behalf of the United States Brain Injury Alliance, thank you all for joining us. We'll archive this webinar at our website, so you can direct other folks to it if you so are interested. And we look forward to having another webinar here in the next few months. Again, on behalf of the U.S. Brain Injury Alliance, thank you and have a great day.
You too. Thank you.
Bye-bye.
Bye-bye. Thank you.
Bye-bye.
He is top.